everyone. I feel like that I say the same thing every time we're together. I always say, I've got something exciting to tell you about, or we're going to have fun tonight because we always talk about subjects I enjoy. We're having our live with CCO tonight, episode 42, and we are going to tell you about pathophysiology. A great subject. I love pathophysiology. Why? Because it's all about the disease process. And the question we're going to answer tonight is how pathophysiology helps the medical coder. Pathophysiology, the course that we offer, is an ancillary course that is excellent to go hand in hand with your coding course. If you are new to the medical field, absolutely you need to take a pathophysiology course. We have some other courses that I consider ancillary that absolutely you would want to consider to bring that knowledge base up. It makes you better as a coder and it helps you code faster and more accurately. If you don't have to sit there and rethink everything, it's just there in your knowledge base, then you're going to do much better at the career that you've chosen. So again, pathophysiology is really the basis of what we do. What I decided to do in telling you about pathophysiology is we're going to talk about what it is, and then I kind of picked a disease and a disease process as well as the treatments and kind of behind the scenes is what I think pathophysiology is. We're going to run through it step by step to talk about and show the benefits of why you need to know this information. The technical definition of pathophysiology is deranged function in an individual or an organ due to a disease. For example, a pathophysiological alteration is a change in function as distinguished from a structural defect. That is way up here. No one should have to break that down. That's going to go over everybody's head. So again, this is not a definition that I would advise anybody to use. More in line with unpacking it and really telling you what it is to say it's a study of the physical and biological abnormalities occurring within the body as a result of a disease. And you break it down even more, then you say it's the disease process. I think that we need to keep in mind that there's several aspects of a disease, and they can be divided up into three categories. We have minor, we have acute, and we have chronic. Now, we recently did a lecture on chronic heart conditions. We recently have talked about chronic and long-term illnesses that cannot be cured. And so we've kind of been this week focusing on pathophysiology. I encourage you to go look at some of our other YouTube and education that we provide free to you. I like to think too that the reason we do what we do in offering these lectures free is to give you a launching platform is, oh, I need to look into that. I need to increase my knowledge base. Or she mentioned a term I wasn't familiar with. I'm going to take time to go out and study that. And I encourage students and coders even to have a little notebook, even if it's something like this, where when you're doing lectures in longhand, just write yourself some notes. Go out and look those terms up. Now, the graphic that I picked is kind of applicable with everything that's been going on the last few years with us and COVID. This is actually a discussion graphic about SARS-CoV-2 virus, which is the COVID-19 virus. So if you look at the lungs, it talks about respiratory failure. Then it goes and talks about the blood vessels, and it says hypercoagulable state, and then cytokine storm. So when we go back to the lungs, it's stating the epithelial cells of the lung, nose, mouth, type 2 pneumonitis in the alveoli. So again, part of the pathophysiology is understanding the organs and the body systems and even breaking it down even farther. Epithelial cells, you need to know what the epithelial cells are. And of course, the lungs, then understanding the process of the lungs, what body system they belong to, as well as nose and mouth, type 2 pneumo. CITES. Now, you don't have to necessarily have that memorized, but you have to know what that is. Type 2, who cares? But the term pneumo should be a dead giveaway as to what we're dealing with. And then look at the next, the hypercoagulable state, which is epithelial cells of blood vessels. Well, we have epithelial cells in our lungs, we have epithelial cells in our blood vessels. That is interesting. That means it might not be exactly what you thought epithelial cells were. When we think of epithelial cells, a lot of times we're thinking, wait a minute, does that we think skin cells when anybody talks about structure cells. And then cytokine storm. Again, you don't necessarily need to know what a cytokine storm is, but it says widespread epithelial inflammatory response. That's what a cytokine cell is. So all of these cells are activated and inflamed, and therefore they aren't able to do their job properly, all the way down on the cellular level. So let's now kind of break down an area and a disease process, and I'll tell you how it relates to pathophysiology. And because I'm going to pick something very common, it's going to allow you to think of the process. And as we go along, I'll mention, why is this relatable to us as coders? Let's start with CAD, coronary artery disease. We've recently done a lecture on that, so take some time after this video to look at that. The main topic that we're going to work through now on the rest of these slides is to go between, use the link between basic medical science and a clinical application. That's what pathophysiology does. So we're going to look at the science aspect of it, that we know about the body and the disease process, and then we're going to apply it to a clinical application, which allows us to treat the problem, treat the disease. And if we aren't able to cure the disease, at least control it, right? If we can't make someone better, we don't want them to get worse. We want them to maintain or improve. And that's how do we know that we can do that, or that it's even the steps to do that is because of the study of pathophysiology. So fascinating. Mm. So I took CAD because not only had we recently talked about it, but there's a little bit of information you may not know. I found this in a study that I'm always jumping out and doing research for abstracts. If you don't know medical abstracts, if you don't know what those are, don't worry. I've linked it at the bottom of the slide deck for the resources. So if you're in our CCO club, of course, as always, you're going to get the slide deck and you'll get the resources linked, as well as the transcript of everything that we're talking about. And in addition, you'll be able to further focus and discuss it over in the club. So let's look at CAD. Uh, for the it states that I'm not going to read this. I'm going to just highlight. So the past decade, what's really changed with pathophysiology and CAD is that they have made a remarkable evolution. I thought this was fascinating when I came across this, and I thought, oh, this is perfect example to show pathophysiology, how it changes medicine as we study the disease process. So there's been some advances, and it's altered the way that we have clinical approaches to treat CAD in both the chronic and acute phases. So a sudden onset of an artery disease, the coronary artery disease, as well as somebody that's at the chronic stage. Now, in the past, whenever somebody has said coronary artery disease, the first thing you think of is high cholesterol, right? Give them something to control the cholesterol in the body. It's all about the cholesterol. Remember, there's things you can and cannot eat. It seems like every time you turn around, every year there's something new. You weren't supposed to eat butter, you weren't supposed to eat eggs, you weren't, XYZ, you were supposed to eat pasta, then you weren't supposed to eat pasta. So really, it's not about that. We're diving down and looking at this from a cellular level, what they've learned, and they have found that it's actually not about cholesterol storage, meaning you've built up all of this cholesterol, which clogs up your arteries, just like when you go by the butter that's not really butter. What is it? It's like margarine, and that it when you leave it out, uh, it will when it or it warms up. It becomes liquid. It doesn't solidify, and then when it gets warm, it solidifies again. So again, we would think that's what happens inside the arteries, or if you've ever seen the lime build up on a glass that with half filled with water that you put in a windowsill, and you watch the water level go down and there's that crusty ridge that's left behind, that would be cholesterol. Now there is an issue with that. There is a disease process that happens with hyperlipidemia. However, they're saying, wait a minute, we've done more research, and it isn't really about the storage of cholesterol, but it's actually an inflammatory disorder. How did they figure that out? I don't really know, but I do have some research that we're going to talk about. This graphic was really kind of cool. I pulled it, also it's notated in the resources page, but these are the vessels of your, let's say it's an artery. So if you have a rupture of a fibrous cap, and that fibrous cap is the bump inside, like a buildup of cholesterol in the blood vessel, and then they've got superficial erosion, and then you have like a calcium nodule that builds up, and you have the erosion of the calcium nodule, then the interplaque hemorrhage, and this is kind of how it uh, destroys hyperlipidemia and cholesterol storage, affects our vessels much more than just showing images of them packed with sludge or yellow gunk lining. Of course, we know how that works, but let's now start thinking about it, instead of clogging the arteries with the cholesterol, what it does on an inflammatory basis. So if it's an inflammatory disorder, how did they figure this out? And it's looking at a chemical in the body that actually is a lipid, which we think of as cholesterol. Lipid is a fat, and it's called thromboxane. Now, don't worry if that's not the proper way to pronounce it. That's the way I'm going to pronounce it. So this is essential, and what it does is it allows the body to clot. It affects the clotting factor of the blood. So when you need to stop the bleeding, this thromboxane is stimulated, and it prevents the arteries and the veins uh, to it restricts them while clumping all those little platelets together. And I've got a graphic where it shows you, and it's these little threads that happen. So what happens is, we know platelets are the blood component that causes the repair, right? So that's kind of what makes the scabs or closes hemorrhaging. That's the clotting aspect of our blood components, is the platelets, and they actually produce this chemical called thromboxane, and then that's actually uh, turned into this, I don't know if I can say this right, but this prostaglandins, and then when a person has high blood pressure or high cholesterol, this is going to have a negative effect on the restriction of the arteries, especially when you have buildup of plaque already. So that's what this chemical does. And we're going to talk about it a little bit more. Now that you know that we're talking about the clotting factor, and you think, how does that relate to an inflammatory disorder? First, let's look at inflammation itself. If you have an inflammatory disorder, it affects a lot of the organs. But I found this great graphic off of a research study as well, that all of these diseases have a disease process to them. I know you recognize a lot of these, and this is when you have chronic inflammation, then you're going to have increased thromboxane A2 activity. So, what they will do is they go test for that. And if you have high levels of this thromboxane A2, then they know that you probably have some type of inflammatory disorder going on in your system. Now, if that's the case, then they have to go find out what's the cause. And all of these, every single one of these diseases has an inflammatory aspect to it. Now, you would have never thought that per se, because again, atherosclerosis is a part of the CAD, and there it is right there at the top. Now, asthma, of course, we think of that as being inflammatory. The lungs get inflamed. And Alzheimer's, though, had you thought of that being an inflammatory, having inflammatory aspects? Actually, it does. It affects the brain and the nervous system and the central nervous system. Of course, cancers, yes, they can have inflammatory aspects because it's cells that aren't acting normally. And when you have something not acting normally in on the cellular level, what it's going to cause irritation. And irritation itself can promote cancer cells. Uh, if you have an autoimmune disorder like rheumatoid arthritis, autoimmune is going to mean your body is fighting against itself, which gets inflamed. So again, all of these really, really fascinating to know. If they go in and they test you for this thromboxane A2 and you have high levels, then your body is running in an inflamed state. You may have an inflammatory disorder. Then they can go from that point to search out and find out what it is, or to if they narrow it down, right? So how does that relate to pathophysiology? Well, understanding the disease process. If you have CAD or you've exhibited signs and symptoms of CAD, they've determined that you do have it, then it's producing in producing an inflammatory disorder in the body on the at the cellular level to the arterial system, the arterial vascular system, which is going to cause problems. And now they've related, had an aha moment and said, okay, it's not all about the plaque, it's also about this lipids that triggers this. So, how do they treat it? Because that's the next step in pathophysiology. We've found a disease, we understand the disease process, it's morphed and gone from what we thought it was and how we treated it to a new level, and so we're going to treat it differently. One of the ways that people have CAD treated is to give them aspirin. What is aspirin actually? So ultimately what it does is it prevents the production of thromboxane. Now, there's more than one type of thromboxane. There's two main types, but I don't want to go into that. There's A2 and B2, but again, A2 is the one they focused on because of the pathophysiology that we've looked at. And when you reduce the thromboxane, then it's less likely that you'll have a heart attack or a secondary heart attack. And we know because of pathophysiology and the disease process that if you have an MI, you're most likely going to have a secondary MI within the first 2 weeks, of the 7 to 14 days. And it's pretty common to have that happen. That's brilliant, right? So again, sometimes the treatment for aspirin is used for some diseases now when it hadn't been used before because it takes care of the thromboxane, right? It change in clinical application and the treatment change. Now, there is a little graphic of the chemical makeup of thromboxane. There's A2 and B2. And, is this something the provider is going to put the patient on who has CAD in regards to their plan of care versus upping medication for cholesterol and hyperlipidemia. That's a thought process that they're studying. So let's talk about the disease process again. We're going to back up. And I know Sarah said, and now doctors have changed their recommendations for aspirin. Absolutely, they have, because of the way they've studied the process, right? It's not for everybody and what's wrong with them. So aspirin also works really well with AFib, but, and then that's another whole pathophysiology, deciding what's right for each patient based on what we know about them, their past medical history, what's happening them now, and also in addition, the best plan of care that the provider comes up with. So, what's the primary function of thromboxane? Uh, it is to stop bleeding. And the way it works is it takes that lipid asset that's in the platelets that clumps and forms a clot, and then it narrows the lipid narrows the arteries leading to wherever there's a cut, and then that makes platelets work not as hard, I guess is the best way to say it. Ultimately, this is how clotting works. Now, if you look at this first little graphic, you see the red blood cells, right? We all know that's a little concave circle. They have one job: carry oxygen. That's it. And then the white would be the white blood cells that you see mixed in there. Their job, they have more than one job, but they're out there taking care of infections and germs and stuff. And then all that yellow thread, that's part of the thromboxane. That's the platelets. Okay, so that's part of the platelets. And what happens when you have a narrowing stricture or of the blood vessels, whether it's part of CAD and stenosis or plaque buildup, you see that little narrowing, uh, that is activated in the system when you have too much of this, and those red blood cells and the white blood cells and other blood components and stuff get packed together and held together with this platelet material, this thromboxane, and pretty soon you just have a knot, and that knot clumps and gets stuck. We don't have free flow of all the blood components that can do their job. And I thought that was an excellent graphic to show you that now, if we were to have something that could break up those threads, the thromboxane, then all those little red blood cells and other blood components wouldn't clump together, and they could free flow through even a narrowed passage, no matter what the disease process was in that narrow passage. So again, get rid of that sticky thromboxane. What does that? Aspirin does that if you have aspirin in the system. So again, now we've talked about the process and a clinical application. So what's next? Well, we want to prevent that clotting. We want to prevent the thromboxane, and now there's several ways to do it. I'm just going down one um, rabbit hole here. So I chose to think about aspirin because of the first comment that was stated in the beginning. Hey, we don't treat it on a lipid level like we need to get rid of the lipids for cholesterol, fat storage. Now we're thinking we want to take care of the thromboxane itself, that it's actually an anti-inflammatory that triggers this thromboxane to start doing its job, and we need to weed that out. So you see how the thought process is going, and aspirin does that. So if we want to prevent blood flow to the heart, then you will clot that blood somehow, right? And that can result in a heart attack or an MI. The aspirin therapy reduces the clumping of the platelets, and now we know the thromboxane that could prevent that heart attack. So again, we've looked at the medical science all the way down on the cellular level, and then we've looked at a clinical application as treatment. What are we doing? We're giving aspirin as a treatment. So is aspirin okay for everybody in the disease process? Well, that's part of the pathophysiology aspect, because it's not right for everybody. There are side effects to aspirin. There's side effects to lipid level medications where we are treating things like hyperlipidemia as well. So again, side effects to any clinical application, but who makes that decision? The provider makes the decision based on all of the information that they've acquired diagnostically from the evaluation and management of the patient, any other documentation that comes in from other providers and specialists, and what they know regarding the latest that has been revealed for pathophysiology and science. So let's talk about some of the side effects. Stroke because of a burst blood vessel. So if you're taking aspirin every day to prevent a blood clot, well, it is actually a thinner. You're thinning the blood out, and if you do that, then you are more likely to have a bleeding stroke, a hemorrhagic stroke. Now, there's two kinds of stroke that you can have: hemorrhagic and ischemic. Hemorrhagic means that a vessel has burst, and let's think of a stroke in the head, in the brain. If blood starts pooling and building up, and they can't get that to stop, it's going to build up and create pressure, which smashes the brain ultimately and causes problems. Right? We don't want fluid building up in our gushy little sponge of a brain and smashing it, deflating it. It's going to cause problems. Those gray cells don't regenerate themselves. We don't want them bruised or damaged in any way. So a hemorrhagic stroke is treated differently. Its clinical application and treatment is different than an ischemic stroke. An ischemic stroke is one where a clot gets in there, not free flow of blood, a clot that stops the blood supply to the rest of the brain. So again, we're not bleeding out in the head, we're actually killing it by not allowing oxygenated blood to get through to feed the brain, and therefore both are stopping the blood flow. We're not getting oxygenated blood to the areas that need to be oxygenated. One is we're leaking blood all over the place. The other is we've plugged it up, and the red blood cells can't get through, or anything else. So again, because that's the pathophysiology aspect, you don't give hemorrhagic strokes blood thinners. You got to treat it differently. You got to go in there and stop the hemorrhage. Now, if it's an ischemic stroke, you do just the opposite. You give them a blood thinner, and now they're so good about it that they can give you medication that will go in and bust that clot up, hopefully really quickly, within if they give it to you within the first hour or so much time. And maybe it's 4 hours, I can't remember. I used to know. Recently I did a lecture on, I just can't remember. So within so much time of the onset, if they give that to you right away, they can bust that clot open, and then you won't have any damage to those little gray cells. But again, they have to know right away, is it hemorrhagic or is it ischemic? Because the pathophysiology is different, and you'll notice in the documentation a major difference. So if you're going to have a uh, stroke that is hemorrhagic, the aspirin as a blood thinner is not for you. Also, gastrointestinal bleeding. For me, for one, I cannot take aspirin. I've never been able to take aspirin. And quite honestly, as a child, I remember taking aspirin, back in the day. I'm old enough that they would give you aspirin after you're a certain age, because you don't want to take aspirin if you're really young, because it can cause a particular fever that is very dangerous for children. So you never give very young children aspirin. It's a major no-no because of pathophysiology. We know that. But again, when you get a little bit older, you can tolerate aspirin. And if you don't feel good or you get a headache, or it's supposed to be really good for a headache, you pop an aspirin, a child's baby aspirin. They tasted amazing. They had this little orange flavor. I loved the taste of baby aspirin, but it didn't do a thing for me. It never has. Now, my husband is a counterpart is completely different. If he has, especially a toothache, a headache, anything, he'll take a couple aspirin and it works great for him. But as I got older, if I were to ever try to take an aspirin, I got horrendous heartburn, really bad heartburn, even if I take the enteric coated. So aspirin is just something I never ever take. It never worked for me, never gave me relief, and the side effects were not beneficial to me. The gastrointestinal upset was too much. Now, and so if I would have kept taking it, it probably would have irritated like an NSAID does, and you get possible ulcers and bleeding ulcers. Aspirin is rough on the stomach. And if you are bleeding with a gastrointestinal bleed to begin with, what do you not want to do? You don't want to give somebody a blood thinner, which aspirin is. Okay, so it and ultimately, yeah, it can be very life threatening, because when you're bleeding internally like that from the digestive tract, you sometimes don't know until it's late. So if it's not coming up and you're not throwing it up in emesis, or you're not passing black tarry stools, you may not know that you have an intestinal bleed until it's really problematic. And then also there are some people that are actually allergic. They have an allergic reaction to aspirin. Again, this is all part of the clinical application that's based on the medical science that we know, the pathophysiology, all coming together from the point of, hey, we just discovered that this disease process isn't what we thought it was. Science has revealed something new to us, and therefore there's a trickle down effect all the way to the clinical application of what works best for patients and what may not work best for them. So wrapping all of this up, uh, that link, what do we do? Well, there's definitely benefits to aspirin. We know that for an MI, for a stroke, for cardiovascular disease that can, cause mortality and even cancers sometimes. But the risk factor is gastrointestinal hemorrhage, intracranial hemorrhage. Who decides that? Based on the pathophysiology and science and what we know, the provider makes that decision. That's why they go to school, to understand the pathophysiology aspect of what we do in medicine. That's why it's a course that's given to all medical students, whether at every level that you're going in, from starting out maybe as a CRNA, being an MA, going into nursing school. Uh, uh, all nursing schools have several courses in pathophysiology, and because you are at that clinical application aspect, and then you've got your nurse practitioners and your PAs, physicians assistants, and your DOs and your MDs working together. So as we know that pathophysiology is such an encompassing aspect. We took one tiny, minute area, cardiovascular disease, and then we took it to one tiny little area of CAD, which is one of the top three killers of people in the United States is cardiovascular disease. So it's very prevalent. So this one little aspect in treatment, we went from the cellular level all the way down to the end of how we treat it and why we treat it with a particular medication, and then the pros and cons of that particular medicine and the medical decision making that needs to be made. Uh, and ultimately, the goal is to give the patient the quality of life that they, if you know, they deserve. Well, I guess not, well, I don't want to say deserves, but that you're looking for. You want them to maintain or improve in the disease process. Now, how does that boil down to a coder? Because we have to follow every single aspect of this. If we don't understand the pathophysiology, then how can we be expected to translate accurately the thought process that the provider has from that cellular level and all the way up to the clinical application? We would be clueless. It would be like saying, you know what, I'm going to go be a Spanish translator for NATO. However, I've only had 2 years of high school Spanish. It's not going to happen, right? You not only don't know the language adequately, but you don't know it on a level that's needed to speak with diplomats and governing bodies of the whole world that are talking. There's no give or take there. You're just not trained. And as we learn pathophysiology, even on the basic level, over the steps that we've gone through tonight, and this is exactly how it works with our pathophysiology course. We start out with different body systems and the diseases from CAD to obstetrics to respiratory diseases and just it encompasses the entire body. And then we move that into educating you on everything that you need to know. Uh, so Leah says, I am not a medical student, but it's very well explained. Well, thank you. Uh, the reason I enjoy pathophysiology so much, again, told you at the beginning, is because it's the disease process. But as we learn the disease process and pathophysiology, it gives us that basic understanding we need to be able to communicate at an adequate level with our clinicians and our providers. And that's what we do. We translate for them. Why? Because we're coding for them, which is just a translation of the disease and the disease process and the clinical applications of what's being done to the patient. We code for statistical purposes first. It happens to be a convenient way to get paid. So it's two part. We want to make sure the statistics for the disease process and the treatments that are used for those disease processes is accurate at the highest level for statistics, so we understand. Then again, reimbursement follows because of that, because if you don't have proper reimbursement, then it's a hard stop, right? Nothing's getting paid for. The lights can't be turned on. You can't buy toilet paper for the clinic. You can't pay the clinicians. You can't pay the staff. Again, you can't get the equipment that you need to treat the patients so that the patient gets better and returns to normal life and activities. It boils down to that. These are the resources that I used today to just talk about the one aspect of pathophysiology. Our pathophysiology course is amazing. I loved helping to put that together. We have an excellent coach who is an RN with a master's degree that is very excited to help you along the way. And I hope that by giving you this information, it allows you to see why you can't skip on your knowledge base and your understanding when of pathophysiology when you go to make this a career as a coder. The course is fun to do, and I would think that the advantage that you would get from it would be that it broadens your horizons, that every body system you'll learn something new, and it'll be a launching platform for you to get out there and do more study on your own, especially if there's an area in medicine that you want to focus on and get better at. Or again, get into general practice where you touch a little bit of everything. Go to the cco.us website. If you want to know more about live events that we have, a minimum of 3 times a week on Tuesdays, Wednesdays, and Thursdays that we stream live on YouTube, Facebook, and LinkedIn, go to cco.us/notify. And if you are visiting us via YouTube, please take a moment to hit the thumbs up. That helps us, and it shows value to the content that we're providing to YouTube so that we get bumped up. So when people go and search for something like pathophysiology, we'll get bumped up. In addition, if you hit the like and you're not already subscribed to our Medical Coding Cert YouTube channel, please take some time to do that. Like us on Facebook, LinkedIn. Make sure you're connected with us. Feel free to go find me out on LinkedIn as well as CCO. I like to post some fun things in there, but absolutely our Lori is always posting valuable content and fun stuff on our social media. Also, check out our pathophysiology course. It's real easy to find at cco.us. You can either go to courses or you can directly go to pathophysiology course itself and see if that's something that you would like to use to bolster your, even if you're already a coder, to bolster your knowledge base and make you better at what you're doing already. Let's see, I'm trying to think if I've told you everything that I need to. I believe I have. There is a little bell in YouTube. Click that and it will let you know if you're, even if you're already on our email list, to notify you. If you're in the CCO club, of course, you're going to find out first before everybody else what's coming up next. I hope you've enjoyed this. Let us know if you did, and we look forward to seeing you again soon. Thank you, guys.
Our Pathophysiology course was created especially for medical coders, billers, auditors, and risk adjusters. The course includes a personal coach, 9 months of online access, and on-demand videos, transcripts, and exams. You can learn more about the Pathophysiology course at www.cco.us.